Hi everyone and a very good morning. I hope you are staying safe in these unusual times. N2 disease in non-small lung cancer is a very topical subject that will continue to attract disagreement between clinicians for years to come. In this presentation, I will speak about the heterogeneity of N2 disease, what's the available guidelines for its treatment, and I will try to highlight the controversies that make this subject a minefield. And finally, a word or two about the future or direction of management of N2 disease. What I will not talk about is the anatomy and radiology of the N2 nodes, or the different strategies of harvesting them. This is a separate topic. I will not compare and contrast the preoperative ways of staging the mediastinum, such as endobronchial ultrasonic biopsy, known as EBUS, esophageal ultrasonic biopsy, EUS, mediastinoscopy, mediastinotomy or Chamberlain procedure, VAMLA or video-assisted mediastinal lymphadenopathy, and TEMLA or transcervical extended mediastinal lymphadenopathy. Again, this is a separate topic. So, where do these N2 nodes hide? N2 nodes have single digits in the 8th edition of the nodal map issued in 2016 by the International Association for the Study of Lung Cancer, also known as IASLC. If we follow the sequence of how we harvest this node surgically, then on the right-hand side, from bottom to top, these will be stations 8R, 9R, 7, 2 and 4R, 3A, and 3P. On the left chest, following the same sequence of dissection, this will be 8L, 9L, 7, 5 and 6, 4L, and 2L. Note that station 7 is a midline group, identical on both sides. In other words, there is no laterality. There is no right or left station 7. It's just one station. Also note there is no right station 5 and 6. So 5 and 6 denotes only left-sided nodes. Why are we bothered by N2 disease? The answer to this question is because it has a bad reputation. Most of the published articles would report a 5-year survival rate around 20%, and the median survival between 1.5 years to 2 years. Unfortunately, N2 disease is quite prevalent, approaching 45% of all non-small cell lung cancers. And this is acknowledged by all the governing bodies that regulate our profession. They acknowledge the controversies with regards to managing N2 disease and attribute this to the heterogeneity of the disease. N2 disease or stage 3A N2 or stage 3A because of the positive mediastinal N2 nodes is not a one-size-fits-all. It's a notoriously heterogeneous group. For example, if one takes any N2 nodal group and factorize the size of the primary tumor with it, then we find a significant difference when the primary is bulky. The 5-year survival rate is around 20% when the tumor is not T4, and hence the IASLC lumped them together in one prognostic group and called it 3A. Whereas with a bulky primary T4N2, the 5-year survival rate is much worse, at around 5 years. Quite a contrast. And the IASLC puts it in a different category and calls it 3B. And the recommendation is not to operate in the latter group. There are other areas of heterogeneity of N2 disease. Again, there's a difference in prognosis between the single zonal and multizonal disease. Single zonal has a 5-year survival rate approaching 34%, and this rate drops to 20% when multizonal disease is depicted. For the sake of clarity, I need to define the difference between a station and a zone. A station is an anatomical location of a group of nodes, used by surgeons and physicians for precise anatomical description. These are well defined in the IASLC map. On the other hand, a nodal zone is an anatomical area that includes one or more neighboring N2 nodal stations. Nodal zones help locate nodal involvement without having to define the exact anatomical location of that node. Some zones include only one station. For example, the supraclavicular zone, station 1, and the subcarinal zone, station 7, include one nodal station each, whereas other nodal zones may include 2, 3, or more nodal zones. For example, right paratracheal zone is a single zone but contains the stations 2R, 4R, 3A, and 3P. The concept of nodal zone is of special value for those patients who will ultimately be treated by chemotherapy or radiotherapy. The precise anatomical location of the nodes involved is not important. Another aspect of heterogeneity is to be found in the location of the nodes. It is generally known that median line cancers have bad prognosis, and median line nodes such as subcarinal station 7 is no exception. If one takes the same size of primary tumor with affected subcarinal nodes, one finds the prognosis to be much worse than the involvement of other nodes. The 5-year survival rate is reduced to 22% if station 7 is involved, whereas it is 35% if stations 2 to 4 on the right or 5, 6 on the left are involved. A significant worse prognosis with the station 7 involvement. The prognosis is even worse if more than one node is involved, so the number of station 7 nodes is also important. Another area of heterogeneity is the timing of the diagnosis of the N2 involvement. N2 disease documented by invasive preoperative clinical staging such as EBUS, EUS, or mediastinoscopy have worse prognosis than N2 discovered on operative specimens, 9% versus 24% 5-year survival rate. This is quite significant. In theory, this difference could be explained by the difference in malignant cell load. The incidental involvement of N2 nodes on operative specimens must be due to undetectable disease by the PET scan before the operation. We have to remember that EBUS and mediastinoscopies, which are classified as clinical staging, are always performed on a PET-positive nodes, and one has to presume that these nodes have significantly higher tumor load than the disease discovered by chance or incidentally in a PET-negative nodes taken at operation. So there is quite a contrast in the tumor load between the two categories. From the previous discussion, it becomes not surprising that a difference exists between the macrometastasis and micrometastasis. Micrometastasis being defined as microscopic deposits of malignant cells of less than 2 mm in diameter. Micrometastases are sometimes detected by flow cytometry, a technique which can depict up to 4 cells only in the lymph node. Prognosis is better when the tumor load is micrometastatic, few cells, in other words. To complicate things further, if more than one node has micrometastasis, the prognosis takes a nosedive. In essence, the involvement of few nodes by metastasis translates into systemic disease, and hence the bad prognosis, i.e., it's too late. The disease has already gone to the circulation. Robinson et al. In 2003 suggested a subclassification of stage 3A due to N2 disease. If the N2 involvement was due to incidental finding of a positive node from unexpected operative nodal harvesting, then they suggest the classification to be 3A1. If the surgeon didn't like a specific lymph node during an operation and frozen sectioned it and found that it was positive, then this is classified as 3A2. 3A3 is reserved for histologically proven nodes by invasive techniques before the operation, EBUS, mediastinoscopy, etc., etc. Stage 3A4 represents bulky or fixed disease on PET-CT with or without histology. The behavior of these groups is notoriously different. In the previous slide, we noticed the suggested group of 3A2, i.e. single N2 node found during surgery. In 2006, Mark Ferguson, professor of thoracic surgery at the University of Chicago, published a very important series of books called Difficult Decisions in Thoracic Surgery. He quotes evidence for the decision of abandoning surgery if such an N2 node was incidentally encountered during the operation. He recommends to abandon the surgery in favor of induction chemotherapy and redo surgery later on. I will show evidence that this recommendation is not valid anymore. Now, we as surgeons want to believe that we are part of a team that delivers bespoke treatment to patients. Multimodality approach has proven to be more effective in treatment of non-small cell lung cancer. We are in partnership with the oncologists and the radiologists. We sit within an MDT meeting that represents the cancer network of the region. Whatever modality of treatment is chosen for a specific patient has to be guided by guidelines. We receive these guidelines from bodies that regulate our specialty, and hence they police our practice. Examples of these bodies are the National Institutes of Clinical Excellence, the Society of Cardiothoracic Surgery, the British Thoracic Society, the European Society of Thoracic Surgeons, the American Society of Thoracic Surgeons, and the IASLC, or the International Association for the Study of Lung Cancer. Where do these governing bodies get their information from? Research. They get it from research. They run their own meta-analysis and come up with the recommendations, as we call it, guidelines. If you look up the definition of the word guidelines in the dictionary, you will find that it means a general rule, principle, or piece of advice. Margaret Thatcher said that guidelines, unlike rules, are not mandatory to follow. They are there to guide you, but not to dictate what you should do. However, in this day and age, one has to be aware of the rising medical legal liability in our profession. If you run into trouble about your decisions of treating your patients, then the GMC will benchmark your duty of care in accordance with a reasonable body of opinion. In other words, what would your pals, your colleague surgeons, do in similar circumstances? This benchmarking is called the Bolam test. Therefore, it's important to know what guidelines others are following so as not to be eccentric or offline from the greater stream of clinicians treating lung cancer. I would like to slightly digress from the main subject and ask the question, do we have to stage the mediastinum? Do we really have to do mediastinal nodal dissection? As a surgeon, you should know that you have a duty of care to stage the mediastinum. You must have a strategy, whatever that is, but you must have one. The NICE guidelines published in 2011 tell us to perform routine mediastinal nodal dissection in all patients, not selectively, but in all patients, even if we do not suspect N2 on the CT or PET scans. The reason for this is you will find that 10 to 15% of routinely harvested nodes are involved with metastasis, even if not expected on the CT or PET scans. We published our own results in Southampton in 2011, and we reported a similar incidence of unexpected 10% N2 nodes. The guidelines from the BTS published on the same year say the same. perform systematic nodal dissection in all patients undergoing curative surgery for lung cancer. Almost all the other governing bodies agree on this issue. And why is this agreement? What is good about nodal dissection? What does it do? What is the rationale? It was shown by good evidence of meta-analysis that stage 2A and 3A, if you follow surgery by adjuvant chemotherapy, the 5-year survival improves by 5%. Now you might think that 5% is not much, but if you look at the Japanese series, this figure rises to 11%. Perhaps the truth is somewhere in the middle between the two figures, around 8% or so, and that is significant. So, by denying your patients the systematic nodal dissections, you are robbing them from the incremental chance of survival, simply by improper staging of the mediastinum. You might think that you do not do nodal dissection routinely, and your patients are not particularly disadvantaged by that. In my opinion, such surgeons would be suffering from PSD, or professional selective deafness. You only hear what you want to hear, and you don't want to hear what you don't want to do. However, this is a dangerous attitude from the medico-legal point of view, as you will certainly fail the Bolam test and could easily fall out with the GMC if your practice was to be investigated. If you were completely altruistic and asked the question, am I going to harm my patients by not dissecting the nodes? The answer to this question is to be found in this publication from Memphis, Tennessee, published in 2014. This was a retrospective study on 25,000 patients on the SEER database. The surveillance, epidemiology, and end result patients from 1998 to 2009. They studied lung cancer patients who did not have their nodes assessed, in other words, NX, and found that these patients had prognosis similar to assessed patients who were found to have N1 disease, and concluded that by not assessing the nodal state, you are condemning your patients to the prognosis of N1 disease at best. So yes, you might be harming your patients. All the governing bodies agree on one thing. In a CT negative, PET negative mediastinum, what I would call innocent mediastinum, surgery must be offered up front, without the need for routine EBUS or routine mediastinoscopy. I repeat, no need for routine mediastinoscopy. The operation should include mediastinal nodal dissection, and that is important. You have to decide your own strategy, whether it is systematic nodal dissection, systematic nodal sampling, lobe-specific nodal sampling, or something else. But you have to have the evidence for what you practice. You must defend what you practice by evidence. It must be evidence-driven. There is no controversy in this decision of upfront operating without routine EBUS and routine mediastinoscopy. However, when it comes to N2 disease, some of the governing bodies recommend that patients suspected of N2 disease should have histological confirmation by EBUS or mediastinoscopy, regardless of operability. If the EBUS of a PET-positive mediastinal node did not give the diagnosis of metastasis, then mediastinoscopy must be performed. In other words, histological confirmation of a PET-positive N2 nodes is mandatory. Patients with confirmed N2 disease will be treated by induction chemotherapy, followed possibly by surgery, but not upfront surgery. However, this is controversial. Almost all governing bodies recognize that there is no role for solo surgery upfront, and unless you mix it with another modality of treatment, it is ineffective. The alternative is a definitive chemoradiotherapy as a final modality treatment. The NICE recommendation, however, gives us a leeway for upfront surgery in N2 disease. It mentions that non-bulky single-zone N2 disease should be considered for surgery, but only within the context of a trial. It does not say you should operate up front, but puts conditions to such decision. The guideline is quite relaxed about multimodality, as it permits surgery with or without multimodality treatment. It also recommends auditing one's results. As a result of this open door, many trials have taken place already. Surgery within a multimodality strategy did not harm patients or delayed their treatment or led to progression of disease while it's waiting for the operation. And that is the minimum requirement of safety. NICE also recognized a subgroup that can benefit from multimodality treatment that includes surgery. N2 has to be proven histologically before carving a pathway, by EBUS, by mediastinoscopy, etc., etc. They receive platinum-based induction chemotherapy and they are restaged again by redo EBUS or redo mediastinoscopy. Only responders who are found to have negative mediastinum should proceed to resection. I repeat, only the responders should proceed to resection, and that will be a redo surgery. If not suitable for surgery by that time, then definitive radical chemo radiotherapy is added. One of the controversial aspects of this induction surgery modality of treatment is the need for proof of downstaging by redo EBUS or redo mediastinoscopy. This is a heavily contested area of discussion. Very few centers in the world perform redo mediastinoscopy. It's technically demanding and high risk. To understand why it is controversial, we need to go back in time. In the 1970s, surgeons used to take patients with N2 disease up front for surgery as PET was not available. Remember, PET was invented in 1974. The surgeons had good 5-year rates at the expense of high frequency of locoregional failures. They therefore experimented with adjuvant therapy to try to improve their results. They were stuck with this business of restaging, which was technically demanding and very few surgeons agreed to it. The results showed clearly there was a difference in prognosis between those who respond to the induction chemotherapy and the non-responders. Hence, the need to identify the responders to proceed to surgery. We then traveled back in time to 2009 when Eric Lim and his colleagues from the Brompton published this seminal paper. It is so important that I swear by it. Eric and colleagues performed a systematic review of the randomized and non-randomized trials looking into the timing of chemotherapy, comparing chemotherapy before and after surgery. Their conclusion is very clear and decisive. They concluded that in resectable lung cancer, there was no difference in survival between the two groups. In other words, it doesn't really matter if the chemotherapy is given before or after the operation. So, if that is the case, why are we delaying the patient's pathway by sending them for further EBUS, mediastinoscopy, to prove that their PET-positive nodes are histologically also positive? If the surgeon is confident to remove the primary and the lymph nodes on that side at the time of the curative lung resection, and then follow that by chemotherapy, why are we really bothered about the PET-positive nodes? We are guaranteed to get the same results either way. To go even further, Eric and a bunch of authors who scripted the European guidelines commented on a later date that they believe, and so do I, that if the primary and the lymph nodes are surgically resectable, then there is no need to obtain EBUS or mediastinoscopy. It's irrelevant. This corroborates the principle of investigating the mediastinum. You only ask for the investigation that will make a difference to your management. Histological confirmation of N2 nodes is as good as what you want to do with this information. You only ask for the invasive EBUS or mediastinoscopy if they will change your management. In other words, neoadjuvant chemotherapy followed by surgery. If you are going to go down this route, then fine, do it. On the other hand, there are well-designed publications which give evidence against surgery. The ESPATIO trial in 2015 studied the outcome in 2 intervention groups. A control group treated by bimodality induction chemotherapy, followed by definitive chemoradiotherapy. The second group was treated by trimodality, with the same regime of induction chemotherapy, followed by chemoradiotherapy, followed by surgery. There was no statistical difference between the 2 groups. One can conclude that surgery does not add to the prognosis and can be omitted, especially that it carries more chances of morbidity and mortality. So there is sort of a conflicting, controversial evidence in the literature. If you are not confused by now, I'll be surprised. The subject is controversial and confusing, no doubt, and it will continue to be like that. Let us home in on the options of treatment for this subgroup of patients with N2 disease. You have one of 3 options. The first option is to induce chemotherapy and follow that by surgery. The second option is to treat definitively by radical chemoradiotherapy, nothing else. The third option is surgery up front followed by adjuvant chemotherapy. Now let us explore the first option. Is there evidence to support it? The answer is yes, there is evidence. The first evidence dates back to 1994, and the 2 historical randomized phase 2 studies from Spain and the Anderson Cancer Center in Texas. Both were published within short time from each other, and both found a statistical difference in favor of induction chemotherapy. In fact, the Ross trial was stopped prematurely after 2 years of recruitment, as it was thought to be unethical to continue the trial. Small number, around 60 patients before randomization, and possible bias in patients' choice was taken against both studies. All patients in both studies had thoracotomy. The S9900 study from the Southwest Oncology Group in North America has also found evidence in favor of adjuvant chemotherapy. This slide compares the 2-year survival rates of the S9900, which studied the preoperative chemotherapy, against the ANITA study, which looked into post-operative chemotherapy. So we were comparing before and after chemotherapy, before and after surgery. You can clearly see that the results at 2 years is identical, which corroborates the systematic review by Eric Lim and his colleagues I mentioned in an earlier slide. What is attractive about this first option? One will have to give it the plus point of being a systemic treatment, and it deals with micrometastasis early in the phase of the illness. So it deals with all those metastatic cells that are swimming in the circulation. It can reduce the size of the primary, perhaps make an intraoperative tumor operable. The patient's compliance is better because patients might be averted to surgery, and if they have it up front, they might not complete the chemotherapy postoperatively. Whereas, if at the start of their illness, they were told they have to do the chemotherapy first, then they will feel obliged to do it and get eventually with surgery, and that improves their compliance. On the other hand, there is a risk that patients starting with chemotherapy might progress into an inoperable disease. This is very rare, but can occur, especially in non-responders. Option 2 is to avoid surgery altogether and go for radical chemoradiotherapy, nothing else. The evidence comes from the Christine Albain study in 2009, published in The Lancet. They found no statistical difference if surgery was added to patients who receive radical radiotherapy. There was a slight increment in the surgical arm, but not enough to register a statistical difference, especially when the surgery was only a lobectomy. However, the mortality rate with pneumonectomy was high, giving the edge to chemoradiotherapy over surgery. There was 30% deaths in straightforward right pneumonectomy, rising to 50% if the right pneumonectomy was intrapericardial and complex, whereas the mortality of straightforward left pneumonectomy was 0%, and it rises to 16% when the pericardium was opened for a complex pneumonectomy. Detterbeck and colleagues performed a systematic review of mortality in adjuvant chemo followed by pneumonectomy. They reported similar high mortality following right pneumonectomy compared to left pneumonectomy, 11 versus 5% for 30-day mortality, and 20 versus 10% for 90-day mortality. Their conclusion is that it is safe for left pneumonectomy but high risk for right pneumonectomy, and the latter should be considered very, very carefully, or possibly not at all. The results of pneumonectomy following induction chemotherapy are not universally bad, and that makes the issue even further controversial. Walter Wieder from Switzerland and his colleagues, they published their experience carried out in 2 European centers. Their overall mortality of pneumonectomy was only 3%, below the international reports. To my mind, one can think of the right pneumonectomy as a syndrome with a bad prognosis. They die of all sorts of reasons, including ARDS and non-cardiogenic pulmonary edema, right-sided heart failure, etc., etc., whereas left pneumonectomy is nothing more than a usual lobectomy. The third option is to make a run for the surgery up front while the tumor is still operable, and follow this by adjuvant chemotherapy. The evidence for this pathway comes from Gaetano Rocco and his colleagues from Italy in 2010. Sat up at the MDT meeting, you might be challenged and cornered about your decision in N2 disease. Will you operate or not? The answer should be, it depends, as surgery is offered selectively. There is no one-size-fits-all. That's the bottom line. There is no controversy with regards to operable lung cancer when the mediastinum is innocent. The patient should go straight to surgery up front and nodal dissection at the same time of the operation. The more advanced category of T4N2 you will definitely not operate upon, even if it is technically possible to remove the primary and the nodes. This is very important. The rationale here is that your operation will make no difference to the 5-year survival rate of the patients, and therefore exposing them to the morbidity and mortality of the operation is unjustified. It doesn't make sense. Now let us take some examples. We said that there is no controversy regarding the operability of lung cancer when the mediastinum is innocent. Have a look at this CT scan. There's a large T4 tumor continuous with the large matted N2 nodes in stations 4R. You will definitely not operate on this patient. Even if it's technically possible to remove the primary and the nodes, you have to decline such patient. And the reason for that is there is no rationale for the operation. It does not make any difference to the 5-year survival rate. And these patients have got bad prognosis anyway. So why add insult to injury at the end of life? It just doesn't make sense. This is a PET scan to demonstrate this point very elegantly. The primary measured more than 7 centimeters and there is an N2 single node in station 4R. Although technically it is easy to do a advanced right upper lobectomy and systematic nodal dissection, the surgeon should decline this patient for operation. He or she is best served by definitive radical chemo-radiotherapy. Many is the time we are confronted with patients who are very young in age, possibly non-smoker, quite healthy and fit, who have such a situation. Should we decide differently? Well, my advice for you is to tell them that the guidelines tell us not to operate. However, it is their choice if they want the operation before their chemotherapy, but this treatment will be outside the guidelines, but they must agree on the postoperative chemotherapy before you start. the first instance of the treatment, which is the surgery. So yes, you can offer it, but it will have to be outside the guidelines, and the patients must understand that they are being treated outside the guidelines. This is important. This is another example of a primary tumor less than 4 cm, staged at 2A. There are 2 nodes with FDG uptake, station 4R, precarinal, which is an N2 disease, and station 10 hyla, which is N1 disease. This is not multizonal, as the description applies only to N2 nodes, and the N1 can be ignored as long as it is technically resectable. This single nodal N2 disease could be offered surgery upfront followed by adjuvant chemotherapy. On the other hand, a similar primary with similar 4R nodes and an active subcarinal station 7 stages the disease as multizonal N2 disease. And despite the fact that it is technically possible to operate and remove the tumor together with all these lymph nodes, the treatment of this patient should not include surgery, as it will not improve the 5-year survival rate. And the patient is best served by radical chemoradiotherapy and nothing else. A change of 1 node, which is a game changer. Again, if the patient is very young and they insist of having the surgery, then you will have to explain to them that this will be carried out outside the guidelines. As a quiz, I would like you to think about the following scenario and formulate your own opinion before I give the answer. A 63-year-old male was diagnosed with histology-proven primary lung cancer with chest wall invasion. The primary is less than 7 mm in diameter. The questions are: will you agree to EBOS discussed and proposed by the chest physicians at the MGT? Question number 2. Is there a role for surgery? Question number 3. If he is fit for chemotherapy, should it be given before or after surgery? Question number 4. Do you need to radiate the chest wall before or after surgery? Here is the PET scan of this patient that clearly shows the likelihood of a chest wall invasion, and the same patient with a moderately FDG-avid node at station 4L, i.e. likely N2 disease. My answer to the above questions will be as follows. The patient should be given the option of upfront surgery in the form of chest wall resection and lobectomy, in addition to systematic nodal dissection, making sure the 4L and possibly the 4R nodes are harvested. There is no need for EBOS, as it is irrelevant. The tumor and the nodes are resectable by less than a luminectomy. The patient must accept upfront that he or she will require postoperative chemotherapy. Otherwise, I usually don't take them on. With regards to induction of chest wall radiation, this has been tried before and there is no evidence that it improves prognosis. Most surgeons would defer this to after the operation. Extent of attachment to the chest wall is assessed and the area is labeled with metal clips during the operation for future radiotherapy. Is radiotherapy mandatory to the chest wall? Would one radiate the chest wall if the margins were histologically free, in other words, R0 resection? This is debatable. The intraoperative observation by the surgeon is of paramount importance in decision-taking in these cases. Many is the time, what is thought to be a direct invasion of the bone and the intercostal muscle is nothing more than just a few millimeters of invasion into the intercostal muscles. And last but not least, one word about the future direction of treatment is how immunotherapy will integrate into the treatment of non-small cell lung cancer. Preoperative treatment with immunotherapy has no track record so far, and has the disadvantage of time. Trials will have to show a response within 4 to 6 weeks, which is the reasonable waiting time before surgery to deliver well-tested modality of treatment, surgery in this case. We do not know if this period of time is enough to cause any significant change before the surgery. Nonetheless, there has been several trials, and they have shown the same result. If you give patients immunotherapy or immunosuppressants before the operation, they show a 38% response or radiological improvement before the surgery is done. However, this benefit is not extended to the overall survival. Targeted immunotherapy are finding new ligands to block almost every week. Here is a list of the most targeted ligands up to our current day. It is not an exhaustive list, and new ones keeps being added to the list every week. The future use of PET is already changing. Its use has become extensive in assessment of response to chemotherapeutic agents and targeted therapy. This allows the use of second-line and third-line therapies if there has been no response, etc. So, in final conclusion, the N2 disease is quite heterogeneous, and this is the main reason for controversy about how to treat it. The controversy will continue. Treatment of this cohort of patients is carved by clinicians discussing the appropriate pathway in an MDT meeting. All governing bodies recommend that we should audit our results. For bulky T4N2 disease, do not operate. These patients are best treated by definitive radical chemoradiotherapy. Non-bulky operable primary lung cancers with N2 disease can be offered either lobectomy or left pneumonectomy, but not right pneumonectomy, even if it is technically possible. For N2 nodes on PET scan, one should not ask for EBUS or mediastinoscopy for histological confirmation. It is irrelevant if you think that the tumor is technically resectable together with the mediastinal nodes. Thank you for your attention. Goodbye.